Welcome to AETCM, the emergency medicine channel. Shall we start, sir?
Yes.
A 27-year-old male came to ER with complaints of alleged history of deliberate self-harm by ingestion of morphine rat kill cake containing anticoagulant rodenticide, that is bromadiolone. On initial 10-second assessment, airway was patent, no pooling of secretions. Patient was able to talk in full sentences. Coming to breathing, respiratory rate was 12 rate per minute. SpO2 90% on room air. Coming to circulation, heart rate was 95 beats per minute, BP 130 by 80 mmHg. Coming to disability, GCS was E4V5M6, GRBS 136 mg per dl. Coming to exposure, patient was afebrile. Adjuvants to primary
In
survey.
exposure, for example, in this case, you initially itself you know the history that patient has consumed bromidol, right? So you know that it is a rodenticide. What type of rodenticide is this?
Anticoagulant.
It's a anticoagulant. It's a superwarfarin type of rodenticide. So in exposure, what is the important thing you should look for?
You should look for any ecchymosis or petechiasis.
Yes, you should look for bleeding manifestation. That's what you should look for. So in this case, exposure means looking for bleeding manifestation. So what are the areas you look for bleeding manifestation?
Gum bleeding,
Yes.
oral bleeding.
More than the skin, you should look for gum bleeding, conjunctival bleeding. Then you can look for ecchymosis anywhere in the body. Okay, fine.
Coming to adjuvants, we took CBC, CRP and BPG. CBC, CRP was within normal
Yeah,
limits.
we don't expect it to be abnormal, right? If at all it's abnormal, what abnormality will you expect in the CBC? For example, this patient has consumed this thing 3 days back, 2 days back. Now patient is presenting with ecchymosis and all in the body. What abnormality in CBC are you expecting?
Drop in HP if is
Hemoglobin. If at all there is massive internal hemorrhage, hemoglobin will fall. Or thrombocytopenia. Thrombocytopenia can cause because patient is going into coagulopathy. There can be increased clot formations also. Consumptive DIC patient can go into, which can cause thrombocytopenia. Okay, then.
Coming to sample history, a 27-year-old male, a known case of depression disorder on tab venlafaxine and escitalopram, came to ER with alleged history of deliberate self-harm by ingestion of morphine rat kill cake, which is around 25 gram, containing 0.005% bromadiolone around 6 hours back. Patient had been to outside hospital with complaints of abdominal pain and recurrent episodes of vomiting. A gastric lavage and activated charcoal was given from outside and was shifted for further management. No history of petechiae, ecchymosis, gum bleeding, epistaxis, hematuria, abdominal pain. No history of headache, joint swelling or pain. No history of oral lesions or cutaneous burns.
Okay.
Coming to examination. CVS S1 S2 was heard, no murmurs. CNS no focal neural deficits. RS air entry was bilateral and equal. GI was soft and non-tender. So further, patient had recurrent episodes of vomiting even after coming to our hospitals. So we had given him initial symptomatic treatment of PPIs and antiemetics. Then fluid was initiated, and we had sent all the labs to look for coagulation profile.
Okay, now let's come to the topic as such. So, a patient is brought to ER with an alleged history of rodenticide. Let's focus on warfarin class today, anticoagulant. So, what type of anticoagulants are rodenticides? It's a long-acting anticoagulants. Okay. Now, there are two types of long-acting anticoagulants, right? First generation and second generation. First generation was warfarin and coumarin. Second generation is the newer superwarfarin. So, second generation was made because rats became resistant to warfarin. So, multiple tablets, multiple exposure to warfarin was required for the rodenticides to act. So, superwarfarin became, even say single dose can kill the rodenticide. Okay, so what are the superwarfarins that we know of? What he took?
Bromadiolone. Or it can be indendone derivatives like pindone, difecinone, chlorofecinone or valone.
Bromethane, all these things can be there. So these are the different groups. Whatever be the group, its action is in the same category. What is action? It's a
anticoagulant, long-acting anticoagulant.
It's a vitamin K antagonist, isn't it? It's a vitamin K antagonist. It's going to stop vitamin K replenishment and activation of vitamin K derived clotting factors. This is the action. What will be the compound be? So we are going to, what are the clotting factors that will get affected?
2, 7, 9, 10.
2, 7, 9, 10 and protein C and protein S. These are the things. So 2, 7, 9, 10 means it is basically in the intrinsic pathway and extrinsic pathway. Both will be equally affected. So this is the basic pharmacology, right? Okay. Now, superwarfarins, even though this patient has eaten like 25 gram of rat cake, one cake he has completely taken. So, availability. Now, this is one of the most dangerous compounds in children, not in adults, in children, because the effect is per kg weight induced. So, the children will be much more potently get toxic doses, if at all. It's rare, but if at all, children is more prone to that than adults. And the thing is, it's very much variably available. You have all sorts of superwarfarin compounds. You have cakes, pellets, grains, paste. So there is a lot of variety in which it is there. So more accessible for children in the house. They may get curious and eat this. Okay. Now, whatever be, you told 25 gram of cake. So is that the toxic dose? What is the usual toxic dose of a superwarfarin?
More than 10 nano.
Less than 1 mg.
1 mg.
Less than 1 mg. More than 1 mg is a toxic dose. Less than 1 mg. More than 1 mg is a toxic dose for superwarfarin. But he has taken 25 gram, right? So is he in the toxic dose?
But it has other composition also, that cake.
So it is not the cake's weight that we look for. It is the percentage of superwarfarin in the cake. That's what Dr. Shasya told us, 0.005 percentage. So out of the 25 gram, only 0.5 percentage is superwarfarin. So 25 into 0.05, you have to 0.5, you have to calculate. Okay, 0.5, 0.005, right? 0.005, you have to calculate. That much is the only superwarfarin compound, which usually will be less than 1 milligram. So that's why it is a bit difficult to get toxic dosage injection with this. But you can if you ingest a lot more, or persistent exposure. Unknowingly you keep eating this or exposed to this. This is one method. This is basically mucus absorption, right? What is another mode of absorption you can get? Inhalation. If it is burned, that burned smoke can contain the compound, which can get absorbed through our alveoli, pulmonary system. That is another method. Very rare, but possible. But the important thing is, superwarfarin, there are instances in which superwarfarin toxicity has happened for mass number of people, like more number of people, in which even death has happened. 2 of those instances were caused by burning of conditions, not inhalation. So even though it is very less, it has caused even mass casualty like features. Okay, so that is taken care of. Let's come to management. So a patient came to you saying that I have taken bromelain 25 grams. What is your first question?
The amount and
amount and percentage is the first question. Obviously, the person has that bots or something, you take that for preference. That's good. What is the second question?
Next, we will ask for any bleeding manifestation.
But more importantly, when did you take? When did you take is very important. Why?
Because already existing cofactors will be present. So presence of symptoms happens only after 12 to 48 hours.
So clotting factor is already there in your body. That clotting factor has to be eliminated, depleted or eliminated, and new clotting factors. That is where this is going to get suppressed. Okay, it's a vitamin K antagonist. So the clotting factors is replenished over 6 to 8 hours. So after that only the inhibition will start showing. So if a patient is coming to you saying that I have taken a cake half an hour back, your blood test is going to be absolutely fine. There is no abnormality. So you have to keep the patient in observation. Okay. So your first test abnormality usually comes after 8 to 12 hours. That's when it starts showing. And the symptomatology, any symptoms that, as we told, ecchymosis, bleeding, everything happens when at least 30% of clotting factors are inhibited. At least 30%. So it takes a lot of time. So the important thing is, if a patient comes and tells you I have taken this, you do INR. INR is normal. Don't discharge the patient if it is acute ingestion. Okay, that is one of the good thing. Then obviously you will look for symptoms, as we told. Symptoms is clearly explained. Now, how are you going to manage this patient? Oh, what are the test of choice? As we told, INR, APTT, INR, platelet. Is APTT and platelet important?
Like you told, if the patient has...
We want a baseline. We want a baseline to see how the patient will worsen or improve, and that's why we take it. Usually, initially, there won't be any abnormality in APTT and platelet, but then patient can go into coagulopathy and DICs. Okay. That's only investigation that is required. There is no other investigation required. Now, management, right? What is the most important factor? What are the two most important factors in management?
Depending on the INR.
One is INR value, but INR value is important, but most important is what? Two things. One is whether he is bleeding or not. Whether patient is bleeding or not, because a bleeding patient requires emergency management. Second is whether the patient is already on
any other anticoagulant.
Warfarins. If patient is already on warfarin, whatever he has taken is going to supra add on the anticoagulation effect. So patient may require prolonged care. Okay, so these are the two major important questions here. Now let's deal with the most obvious thing, bleeding patient. So a patient is having spontaneous bleeding. There are two types of bleeding, mild bleeding and major bleeding. Mild bleeding is our ecchymosis, gum bleeding, and what is major bleeding?
Gastrointestinal bleeding,
systemic bleeding, systemic bleeding, hemarthrosis, gastrointestinal bleeding, hemoptysis, intracranial hemorrhage, or any bleeding into a major system is a major bleeding. So mild bleeding, how do you proceed?
Conservative treatment, and we can give vitamin K prophylaxis.
Yes, correct. So conservative treatment, you recheck INR every 12 to 24 hours. You recheck INR, but since patient is having bleeding, you are going to admit the patient. There is no discharge here. You are going to admit the patient, and you are going to start treatment. Treatment is vitamin K
0.3 mg per kg. Max dose is 10 mg.
Yes, so oral vitamin K is what you are going to give, not IV. Why IV, not IV? Do we give IV vitamin K? We do. Where? In major bleeding. Minor bleeding and in non-bleeding conditions, we don't give, right? Why? Vitamin K can cause anaphylaxis. It is a anaphylactic drug. It can cause significant anaphylaxis. So risk versus benefit wise, only in major bleeding we are expecting severe bleeding complication. That's why there we understand the risk and give IV. In all other conditions it is oral. Okay, sub-Q we can give, but oral is preferred. Oral is okay for it. So oral tablets is available, or IV preparation can be given oral. Okay. Now, oral dose is what Dr. Shasya told. 0.3 to
0.3 mg per kg. 1 to 2.5 mg tablets are available.
Yeah. So in pediatrics, you can go from 0.2 to 1.5 mg per kg to a maximum dose of 10
Adults?
10 mg. 10 mg. Yeah. 10 mg is what you start. How long will you give?
Superwarfarins are very long acting.
Yes.
120 days of half-life. So we'll have to continue for 2 to 3 months.
So treatment is not for 1 or 2 days. It is ongoing treatment. So even after the initial coagulopathy becomes normal, patient has to be continued on vitamin K, and weekly once or something we have to recheck and see whether patient is prolapsing into another coagulopathic episode. That's important. So this is what you do for minor bleeding. What about major bleeding?
We have to give FFP and prothrombin concentrate.
Yes. So what is the drug of choice in major bleeding? Drug of choice will be a drug that can supplement 2, 7, 9 and 10. So what is that drug?
Vitamin K injection.
No.
Cryoprecipitate.
Cryoprecipitate, but what is the drug of choice? PCC. Prothrombin concentrate. PCC is the drug of choice for superwarfarin treatment, because PCC has 4-factor PCC has 2, 7, 9, 10 and protein C and protein S. So whatever is getting inhibited, we are going to supplement it. Okay. Along with it, there is 3-factor PCC. If both of these are not there, then your choice is FFP. In our country anyhow, since 4-factor PCC is quite expensive, our choice is going to be FFP. Okay, so FFP has all the clotting factors adequately in them. So you transfuse patients' clotting factors which are inhibited will be replenished by the current clotting factors. How much will you give? 15 to 30 mg per kg. 50 to 30 ml per kg. So maximum 2 to 3 FFP units is more than enough for transfusing. You don't have to transfuse huge amount of FFP. Okay. Now, how long will you transfuse? Till the INR becomes normal or bleeding stops. This is the indication. Now, the PCC have some dosage criteria. So there is a weight-based dosage criteria and 25 to 50 and international units fixed dosing criteria. So weight-based dosing criteria is basically INR based. More than 2, less than 4 is 25 mg per kg. Maximum of 2,500 units. MG, sorry, 25 international units per kg. Maximum dose of 2,500 international units. More than 4, less than 6 is 35 international units per kg. Maximum of 3,500. Then you have more than 6. More than 6 is 50 international units per kg. Or maximum of 5,000 units. Basically, whatever units you are giving, add 2 zeros to the right of that. That is your maximum dosage. Okay. So this is PCC dosage. If at all you have to use it. Okay. Now coming to FFP, we told, PCC we told. This is the management of acute bleeding. Now, what about non-bleeding patients? Patients is not having bleeding, but INR is elevated. What to do? If INR, we have to check the INR. If INR is more than 4.5, then we'll have to give prophylactic vitamin K. Yes. Any INR less than 4.5, conservative management, wait and see. There is no requirement for emergency management at all. There is no FFP, there is no vitamin K. Anything more than 4.5, start vitamin K oral supplementation like in minor bleeding, and you continue it for months. Okay. You can discharge the patient, but you have to, what advice you have to tell the patient? Every once in a month. Once in a week, check INR and see what is the level. Another thing, be careful. Don't fall down or hit your head. This thing, advice you have to give the patient. You have to tell them to be extra careful about their surroundings and their situations. Okay, because if they fall down and hit, they are going to bleed. Okay. Now that is a non-bleeding patient who has taken superwarfarin. Now, what if a patient on warfarin has taken superwarfarin? Treatment is still the same, except it is not INR based. Here it is symptom based. Is the patient bleeding or not bleeding? Not bleeding, it is vitamin K oral tablets and monitor the INR value. Here, normalization of INR is not the goal. What is the goal? Goal will be to normalize the INR to the therapeutic level. So this patient was on INR for some condition, isn't it? It can be some valve replacement, it can be DVT, it can be AF, whatever be. So there is a therapeutic INR level the patient had to maintain. So if the patient is on warfarin, taken a superwarfarin, but not bleeding, we'll start oral vitamin K just to make sure that INR comes back to therapeutic level, not zero. Except in bleeding cases. So warfarin patients exposed to superwarfarin presents to you with major bleeding, you are going to reverse the warfarin effect. You are going to normalize the INR. But important thing is, when you do that, you have to look for thrombotic events. So whatever thrombotic event patient was on warfarin, for example, DVT, pulmonary embolism, AF with this thing, it can get precipitated. So that has to be observed for, and then you can reverse the INR. Once INR reversal is achieved, then itself you should start anticoagulation to prevent further risk of thromboembolism. So you have two problems, and coagulation causing bleeding complication and reversal of warfarin causing thromboembolic complication. So initially the bleeding complication outweighs thrombotic risk. That's why you reverse INR. Okay, but when INR gets reversed, now your bleeding risk is too low. Your thrombotic risk is very high. So you have to restart anticoagulation. What will you start? What was the patient on? Warfarin. What will you start? No. Warfarin takes 5 days to act. You start on
low molecular weight.
Low molecular weight heparin or heparin you start it. Okay. So this is the major treatment part. In any superwarfarin common patient, since treatment is for months, and if patient is asymptomatic, textbooks say do not admit the patient. There is no indication to admit the patient, is what it is written. Our practice may vary, depends on where we work, but why they are telling not to admit is only because the treatment is not short-timed, it's prolonged. Okay, any bleeding conditions you need to admit. Okay, so what happened to this patient?
We are serial monitoring of
INR is happening. Okay. Anything else? That's it, no?
Yes.